Good morning, everyone, and welcome to the viewing and listening audience to this, the 21st meeting of the Joint Select Committee on Social Services and Public Administration. This is the committee's second public hearing with stakeholders pursuant to its inquiry into Trinidad and Tobago's response to the prevalence of non-communicable diseases with specific focus on diabetes, cardiological diseases, and cancer. Members of the public are invited to submit their comments on the Parliament's social media platforms, including a YouTube channel, ParlView, or via Facebook and Twitter. At this point, I'd like to welcome our stakeholders who are with us today. And the stakeholders include the Diabetes Association of Trinidad and Tobago, the Trinidad and Tobago Heart Foundation, and the Trinidad and Tobago Cancer Society. At this point, I'd like to invite members of this committee to introduce themselves, starting with Member Beckles.
Good morning, Chair. Good morning, everyone. Penelope Beckles, Member, Minister of Planning and Development, MP for Arima.
Member Naked, good morning.
Good morning, Chairman. Good morning, everyone. Thanks for coming in, and hope you have a productive session.
Member Mohit.
Pleasant good morning, Chairman, all members, and all of those from the various agencies. Member Mohit, member for Shibona Cease.
Member Monroe.
Pleasant good morning, Chairman. Pleasant good morning, all. Welcome. Roger Monroe, Vice Chairman, member for Topo Sanigrani.
We'll be joined in process by Member Esmond Ford and members Ruhan Sinan and Avinash Singh are both unable to be with us today, and the committee's chairman, Paul Richards. At this time, I'd like to invite members of the Diabetes Association to introduce themselves.
Good morning, everyone. My name is Andrew Danu. I'm the president of the Diabetes Association. Thanks for inviting us. Look forward to the conversation.
Good morning, everyone. My name is Shobha Dakaran. I'm the first vice president for the Diabetes Association.
Thank you. Dr. LeBlanc of the Cancer Society. Oh, she'll join us in process. And of course, Mr. Maharaj of the TNT Heart Foundation. Good morning.
Hi, good morning, everyone. My name is Amit Maharaj, and I'm the manager for the Trinidad and Tobago Heart Foundation. And thank you for having us today.
Thank you. I'm the committee's chairman, Paul Richards. We are concerned with three objectives in this inquiry. One, to examine the efforts of the state to counteract the effects of specific non-communicable diseases, NCDs, within the population, including diabetes, heart disease, and cancer. Two, to examine the efforts of civil society to counteract the effects of non-communicable diseases or specific non-communicable diseases within the population, including diabetes, heart disease, and cancer. And three, to determine the main policy changes, actions, and interventions that are necessary to effectively respond to the increase in non-communicable diseases in Trinidad and Tobago. At this time, I'd like to invite Dr. Danu, as president of the Diabetes Association, to start with brief introductory statements. Dr. Danu, go ahead, please.
Thanks, Chairman. Thank you again to the committee for inviting us and allowing us to take part in these consultation sessions. Diabetes in Trinidad and Tobago has now grown to proportions where we have about 15% of our population living with diabetes. Now, these are estimates because the last time a national study was done was in 2011. So these estimates done by the International Diabetes Federation would have been what we are relying on. We have, of course, seen the increase in prevalence of diabetes and, of course, the impact of diabetes. And not just diabetes in older people as we would have thought previously, but we're now seeing type 2 diabetes more and more in younger people. Of course, we do have type 1 diabetes in our young children, and we've been working with them for quite some time on this and working with them to manage the disease. But with type 2 diabetes and the increasing prevalence of type 2 diabetes, the increasing prevalence of the risk factors which lead to type 2 diabetes, and of course, the increasing numbers of consequences, which include amputations, which include renal disease and loss of eyesight. We're seeing this more and more, and we're not attributing this to the fact that it may be sometimes difficult to get the treatments on time. More so, people are hesitant to seeking treatment when they're supposed to. So there's so many factors at play here when it comes to leading to these issues. And we have been doing work over the past 35 years at the Diabetes Association, working quite closely with the Ministry of Health, I must say. There's so much more to be done, but I do want to commend the Ministry of Health for working with us at the association, and of course, commend all of our members and volunteers who have done this work over the past 35 years.
Thank you so much, Dr. Andrew Danu. Can we go to Mr. Amit Maharaj, the manager of the Trinidad and Tobago Heart Foundation? Mr. Maharaj.
Hi, good morning, everyone, again. So the Trinidad and Tobago Heart Foundation is primarily focused on the preventative aspect of cardiovascular disease through education and awareness. And our initiatives include lectures, public health fairs, trying to educate the public in different modes across Trinidad and Tobago. We have also focused on the younger generations. So we are we have been hosting cumulative school lectures to educate younger children of secondary schools across Trinidad and Tobago on steps to prevent heart disease and stuff like that. We're not primarily medical in terms of being integrated into the public health system or anything like that, but we do notice, because of our proximity in working within the hospitals and with the Ministry of Health, that there have been, for persons who do suffer with cardiovascular diseases, longer than optimal wait times to get their tests done through the hospitals and stuff like that, which has, it is delayed, and oftentimes they have to seek private care. And not many of them are able to facilitate that to, maintain their health in terms of cardiovascular related diseases.
Thank you so much, Mr. Maharaj. And let's say good morning. And we're joined by the chairwoman of the Trinidad and Tobago Cancer Society. Good morning, Dr. Asante Leblanc. Could you give us a brief opening statements? Thank you for joining us this morning.
Hi, good morning, everybody. Sorry to be late. On behalf of the Trinidad and Tobago Cancer Society, we are pleased to be joining this meeting. We hope it's not the first and last, or third and last. We really need to address all of the non-communicable diseases, the chronic non-communicable diseases, or NCDs. From the Cancer Society standpoint, we are seeing more and more inadequacies and inefficiencies in the public sector when it comes to both screening, diagnosis, and treatment when it comes to cancer. And we are recognizing also the lack of enforcement of the Tobacco Control Act, and we're pushing strongly for vaping to be included in that, because that is overcoming the tobacco, the smoking itself, cigarette smoking, and that in itself has a huge negative impact on all NCDs and especially cancer. So we're hoping that we can bring that to the forefront, that we can actually effect change and really make a difference, because the population is indeed being affected by NCDs.
Thank you so much, Dr. Leblanc. Okay, we'll start with the Cancer Society. Can I go to Member Beckles to start our line of questioning, please? Member Beckles, go ahead, please.
Okay, thank you again, Chairman, and let me join with all my colleagues in welcoming everyone for what is a very, very important exercise. So can I ask, first to the Cancer Society, can you tell us a bit more about the society's affiliation with the American Cancer Society and what are the benefits of such affiliation?
Sure. So the Trinidad and Tobago Cancer Society became affiliated with the American Cancer Society in 2023, and this was in the purpose of the Global Relay for Life. So the Global Relay for Life is a fundraising event, but also a campaign that brings awareness worldwide. So it's something that happens all through the world where we have relays, and that allows us to bring more awareness to screening, to hope, and to what survivorship is really about. So that is our affiliation with the American Cancer Society at this time. It's just being a part of the worldwide community for Global Relay for Life, and it helps us to network further with our counterparts in the region and also worldwide to fight cancer. It allows us to share information and have an interchange on what can be done policy-wise in our countries. It allows us to also brainstorm to effect proper change in each country and allow to support each one another to effect change both nationally, regionally, and internationally when it comes to the fight against cancer.
Thank you very much. Could you, in terms of your submission, you outline some of your projects and initiatives over the past 5 years. So can you indicate whether you conduct screenings as part of your outreach initiatives?
Definitely. We, as the National Voice Against Cancer, the Trinidad and Tobago Cancer Society includes in its services a clinic. The clinic is highly subsidized through the subvention from the government, which allows for high quality screening services at a very subsidized price to the public. So our screening services include at our clinic at 69 Dundonald Street, and also we have mobile screening units. So our screening includes on-site mammograms and breast ultrasounds, clinical breast examinations, pap smears for cervical cancer, the FIT for colorectal cancer, and the DRE and the PSA for prostate cancer. We do hope to improve more, and then our mobile screening is clinical breast exam and DRE and PSA for prostate.
Okay. Thank you very much. So thank you. You gave us indicated about the subvention. So can you give us a value of the government subvention over the past 3 years? Could you indicate whether there is a shortfall? If, what is the shortfall between what is requested and what is actually provided by the government? And could you also indicate what is the estimated total amount received from the private sector and individuals? And you can just give that for the period 2023. Thank you.
Sure. We had an issue a couple of years back where our subvention was extremely delayed. We used to get 1.5, if I'm not mistaken, and then we didn't get anything for years, and that was about 5-6 years ago. So we had to have a negotiation, and we forfeited that subvention that was missing for years, and then we accepted 750,000 per year. We received that subvention. We have to fight for it, but we get it. It is not enough, but we manage. We have tried to initiate talks with ministry to get that increase because we also have a hospice that we manage as well. We have not had any success where that is concerned. But apart from that, and we understand the position of the government, we appreciate what we're getting. Yes, we would like more. We do much more. We can do much more if we get more. But we also try to make up through private sponsorship with corporate. Through corporate, we have several main fundraisers. So we have the flagship CIBC for prostate cancer. We usually receive from them on average, maybe some years we got 150. Last year we only got about 100, a little short, over 100,000. We have Scotiabank Foundation, which is for the breast cancer, for women's breast cancer screening, both in Trinidad and Tobago. And we got 250,000 from them. And then we have Republic Bank. Republic Bank does, they give us $500,000, but it's for not only for screening, it's also for the Power to Make a Difference program, which is where we do our flagship fundraiser, which is Bubbles for Life. From there, we raise approximately 300,000 net when we take out all of our expenditure, and that all goes towards screening and operations of the Cancer Society. Apart from that, we may get grants from people who have died. We may, somebody may donate, they may buy a tree of life, a leaf of life. On our tree of life, we sell leaves, we sell branches online, so we get donations that way. but it's mainly through corporate sponsorship and our fundraising events that we do.
Okay, thank you very much. Now, in your submission, you mentioned that the TTCS is a member of the NCD Alliance formed by the Ministry of Health, and there may be room for more collaboration with all the partner organizations to execute more initiatives. So, and that was part of your submission. So can you provide some further details in your role in the NCD Alliance and some of the activities that you have participated with in the NCD Alliance since its inception? And can you also tell us what sort of initiatives you would like to see executed through this collaboration? And can you describe some of the opportunities for greater stakeholder collaboration?
Yeah, so I think the panel should know that I'm a very frank person. So please excuse me for my frankness at this time. So the Trinidad and Tobago NCD Alliance was formed. We were one of the core members forming the NCD Alliance because we saw a need for more partnership when it came to NCDs. However, the NCD Alliance is, to me, not able to effect anything because we're not as cohesive as we should be. That is basically because in the NGO world, we're still all fighting independently to make sure that our independent organizations get to do what they're supposed to do in terms of our mission and our vision. I would like to see that the lead in the ministry, the point lead in the NCD department in the ministry, meets with us more frequently and allows for better collaboration. Meetings should not be called today for tomorrow. It needs to be better planned. You need to understand that a lot of us are volunteering. A lot of us have very busy schedules. And therefore, when we miss the meetings, vital information is not given. I find that there's a lot of talk and no action. So I personally miss some of the meetings because I'm tired of talking. I'm tired of begging. I think we need to act. This should not be a one-off. Today's this day and we're going to do this. You need to recognize we need to be more cohesive and we need action. We need better communication with the ministry and be serious about it. It's not for a photo op. It's not for recognition. It's not for commission. It's about the nation and the population. And I really find that the NCD Alliance has not been able to speak as a group and act as a group because we're not given that presence as a group. Therefore, individually, each organization has their different strengths. So, for example, Andrew with the Diabetes Association, he has tremendous strength in the Ministry of Health, and I'm not bashing Andrew because diabetes is a low-hanging fruit, and therefore it's given a lot of stuff. Cancer is not so much of a low-hanging fruit when it comes to diagnosis because of the cost of it, and therefore it's a struggle. But we're asking not only about the diagnosis and the treatment, but you're asking about making a change on the lifestyle for the population. And that is not being done because we're not looking at it realistically. There's a big talk about helping lifestyle of the people, but when we tell you what you need to do, it affects your economics, it affects your trade, and so it's not being done. So we're spending top in mud. We're not doing what we're supposed to do. So we have to do better. And for the NCD Alliance to work, we have to be given that seat at the table. Dr. Clapperton has to hear us. We have to be more cohesive, and we have to truly commit to change. I'm very sorry, but that is my blatant truth.
Well, thank you very much. So then, can you provide some recommendations for improving Trinidad and Tobago's response to the NCDs? I know you're, in terms of what you just said, some of it is there, but would you like to give us anything specific?
Yes, number one, we need to have mandatory reporting of the NCDs because that allows us to get the data. We're no longer talking in the general. We're no longer talking, oh, this is what WHO says. Let us see what is happening in our environment. We need to have mandatory reporting of the NCDs in both public and private sector. Let's start with public. We'll go on to private later, but let's start in public. We need to effect the Tobacco Control Act. We need to ensure we include vaping in that because that's a big thing for all NCDs. It's not only for cancer. We need Dr. Clapperton or the point lead for NCDs to give us a seat at the table as the NCD Alliance and to meet with us and let's bite the cake piece by piece. We don't want to eat the whole cake. Let's sit down and get it done. We need let's get it done. Let's meet. Let's have those discussions and let's take piece by piece. We need our registry to be looked at. We need to have that done. We can't think that these things can't be done. There's paperwork after paperwork after paperwork. There are files, there are meetings, there are committees, there's everything, and nothing is effected. So I'm asking if we can start with first meeting Dr. Clapperton. Tell us where we're at. Tell us what we need to do and how we can start. It's step by step, one day at a time, sweet Jesus. That's all we're asking for. Yeah? And meet with us, talk to us, and let us see how we know that the real world exists. So I'm not asking you to be ideal and cut out everything and all the sugars out of the world. And no, but let's do something. Let's show that we're doing something. And we have to do it from the top, from policy. If we don't affect the policy, we cannot have the change we need.
Thank you very much. So, Chair.
Thank you so much, and Member Becker. So thank you, Dr. LeBlanc, and don't apologize for being frank. That's what we're here. We're actually here to get the information we need. We're not here for only polite conversation for presentation's sake. We want the information from you, the stakeholders, on the ground of what your experiences are. That's the only way we can get the data to make the recommendations that need to be made. Just before I move to Member Mohit, if you could just elaborate a bit on what aspects of the Tobacco Control Act you think are not being effectively operationalized or applied, one. And two, in terms of data collection, do you, the society, do effect any data collection? And what type of data collection would you like to see from the public and the private healthcare sector in terms of what they're getting from the feedback from the public and the incidences of cancers? Because we quote global statistics, we quote regional statistics, we quote national statistics, but very often the national statistics we quote are a year old or 2 years old, which doesn't deal with the problem. 5 years old, there you go, which doesn't deal with the problem, and you can't track the progress of the issue, particularly as relates to cancer in Trinidad and Tobago.
So with the Tobacco Control Act, what we're seeing is that, obviously, tobacco is still there and we have the suitcase trade of tobacco, but our main issue right now is because when we look at it, we can see where vaping should have been there, but because of a change of word, the ends or the electronic cigarettes are not included. And we need to address this because vaping has become a huge epidemic in Trinidad and Tobago. When we're allowing advertising of vaping to our teens as something to do and a way to quit smoking, when it's really a way to hook them onto smoking and other drug use. And when we're allowing ads on TV, on radio, on social media, we have a problem. Especially if our World Health Organization is saying vaping is bad. How on earth are we not making a change? How on earth? What are we waiting for? Why do we always have to follow fashion? So that's not.
So are you saying that the present format of the legislation does not accommodate vaping, and vaping is being advertised as contrary to smoking, because smoking has been banned from being advertised. So there's a lacuna there that needs to be fixed.
Exactly, because the same tobacco industry is manipulating it. And therefore, they're saying, oh, don't smoke, vape. Come on now. I mean, it's being touted as something safe and fashionable, and it's wrong. And we have the data to prove it. If you look back when Whitco came out to announce at their AGM last year how good they did, but they had fallen sales because you all gave heavy tax on tobacco. But don't worry, because they were coming into the vaping industry and all the data we give was wrong. I retaliated. I spoke out and I said, you're wrong. But nobody followed on that. They're wrong. And it's plain and simple. We have to nip this in the bud.
Thank you. And just before I go to Member Naked and Mohit, and the issue of data collection and the accuracy and the timeliness of it.
Right. So we are presently starting data collection on our own site. We're going to do it through our EMR because we noticed that we were depending on the registry before, and then the registry went defunct, and then it started again with IARC. But what happens is it's a population-based registry. So the data that comes there does not identify if, for example, patient A smoked, ate badly, got cancer, and died. It just says, these people had cancer and this amount of people died. So you can't make a correlation. So we are trying to work on data collection from our end in the Cancer Society to then extrapolate. When it comes to the inefficiencies or the disappointment or frustration in the public sector with treatment of cancer, we, as soon as we get the word through our survivor network or through our networking with other groups, we bring it to the attention of the ministry and the powers that be. Dr. Mike hears from me all hours of the day because of what's happening. And it's really frustrating.
Thank you, Member Naked, and then Member Mohit, you can go ahead, please.
Okay, thank you, Chair. Mr. LeBlanc, I'd just like to get some substance, a couple of things that you indicated before. You said that you get $750,000 after negotiations from the government, and you do get some corporate sponsorship, correct? What indicators, what are your overall operating costs? for the year? What are your costs for the year that you would need?
Monthly, our costs are approximately 300,000 per month, with salaries for our staff and everything else, and looking after our imaging and all of that, because we have a contractor that does our imaging for our mammograms and our ultrasounds.
300,000.
So roughly
For the year, 3,600,000.
Yes.
Right. And you get some. So does the corporate sponsorship, does that contribute to the shortfall? No.
No, we work our tailbone off, and our contractor for imaging gives us a very huge blight. So we're in huge debt to him because of that. So we're really working hard to break down that debt. But I'm telling you, the word nonprofit really fits us. There's not a single dime. So we just work hard, and we're doing this, and we're not going to stop because of that. We have to continue working. So this is really for you to see the goodness and of professionals that we have there, that we have a relationship with. They understand it, and so we do have to just keep working with them, and they work with us. But we don't, by no means are we looking at you smiling at the end of the year saying, well, we don't owe anybody. We have huge debt.
But then the question needs to be asked. Given that, I hate to put you on the spot, but given that shortfall, although you look like you don't mind being on the spot, or given that shortfall, people actually dying because of that lack of budgetary allocation? Do people die? Because
we continue to commit to screening. So we don't just sit back. We continue fighting to get more money. So we continue fighting for fundraising for our screening programs. So we don't say no to a single person. So if they call me and this patient is in need and we need a pro bono, we do the pro bono. We do not allow, from our end, we do not have that shortfall, because we do screening, education, and palliative care. We do not do treatment. Yeah. But we are there for the population and also advocacy at this point in time. So we don't allow that. But if we had more money, we could do much more. But at the same time, you can't give up, and it takes two hands to clap. So we understand, and we work with corporate, we work with public, and we right now, for example, we're looking to have a collaboration with the cricketing world. You understand? Because I went out to Miami, I did a 5K for sarcoma, and recognized that the sporting world was sponsoring, because that's a part of their CSR. So I reached out to the cricketing world and I said, why are y'all not doing this? Right? Because they're affected too. They lose family members too. So we're in talks with that. So we don't sit back. Every day in my bathroom, wherever I am, I'm thinking of how we could fix this. So we trying to fix it, because at the end of the day, we see where we are filling the gap for the public sector. We help you all with your screening campaigns. We don't look for any. We go to Tobago. Tobago just started. They wanted to say how they were the only ones doing the screening when we were doing the screening for them. And I said, absolutely not. You're not going to take credit. And it's not about credit. It's about understanding the collaboration. So you can say that the Cancer Society collaborates. We're there to help you. We're there to help you however we can, and we're not going to stop.
Thank you very much.
Thank you, Member Nakin. Member Mohit, go ahead, please.
Thank you, Mr. Chairman. Just a few questions on access to screenings. As it relates to your submission, and we thank you for your submission would have stated that based on patient feedback, there are frequent reports of equipment failure, and therefore these failures delay the access to timely screening services. So I have two questions as it relates to this in terms of the health facilities and in terms of equipment itself. So if you can provide some examples of the public health facilities where your membership has encountered dysfunctional equipment on a regular basis, and if you can provide to the committee examples of some of the equipment that have been reported to be frequently dysfunctional at the public healthcare facilities.
Oh, clearly, all of them, every single regional health authority. So we're talking Grande, Sando, Tobago, Northwest, and North Central, all of them. And the equipment that is being cited is the mammogram, and also there's a huge delay in colonoscopies. Yeah?
And
so that's a huge delay.
How has this affected your membership?
It affects affects them greatly because they can't get the service that they've paid their health surcharge for. Sometimes they're even misinformed that they don't have to do certain things, that they don't have to do it. And that's ridiculous. So it affects them because then when we educate, every Tuesday morning I'm there educating, every time we're educating on social media, get your screening done, get your screening done. And then they reach out to us and say, but we tried. I have patients who are waiting years for a mammogram, years for a colonoscopy. It's not right. We need to do better. We know what the mandate is. We know what the guidelines are. We need to do better.
And have you had any collaboration in terms of the Ministry of Health, these ERHAs and your regional health authorities, as it relates to these equipment challenges for your membership or anybody else, to have something done so these issues can be dealt with as soon as possible in terms of these testing and
We were approached once by NWRHA. If I'm not mistaken, it was last year. We started the talks. We said this is what the price would be. And it wasn't a heavy price. We gave them the subsidized price because they're government and we're there to help. And we never heard from them again. So the thing is that there's always, you might have a reach out, but something stops it. The bureaucracy is immense.
Additionally, your submission indicated that access to cancer treatment drugs shortages has always been reported by your membership. And we have heard it too in recent times. If you can provide for us some examples of the treatment drugs that are frequently unavailable and whether your association would have raised the issue of the shortage with the Ministry of Health officials.
Yes, sorry, I have a patient. I just need my staff to take out. Hold on, please. 1 second. Okay. So what happens is when we listen to the membership, and so the drug names, we do not have the exact drug names, but there's always a shortage of breast cancer drugs, for example, prostate cancer drugs as well. So what happens is, and when I speak to the oncologists in St. James, for example, what they're complaining to me about is that while we have approved the newer drugs for treatment, they're on formulary, they're still not available. So then we're giving antiquated drugs, if at all, to the patients. And so this is a big problem because then they go private, they get the drug that's approved and they have to pay for it privately to save their life or they have to die.
Any reasoning for why it's not available?
You're asking me?
Well, I'm asking you because I'm not sure if any reasoning, were given to you. Any proper reasoning?
Yeah, well, there's never proper reasoning. But it's lack of funds. That's what we hear. That there's a huge owing on the part of the government, and so the drugs are not being brought in. And the thing is, I've been approached, for example, by a drug company, and they said to me, we are willing to talk to the government. We have drugs. We're willing to give drugs for free. I hear those words, but yet it's not happening in the public sector. So they're asking me to be the ambassador to get those drugs for free, but I can't get a meeting. You understand? Because I need to understand what that entails. Why is that not happening? If we're being approached and we're being given that opportunity, why not explore it? I'm not saying take it because we have to be cautious when you're affiliated with a drug company. You can't be affiliated with a drug company. But let us see what is being offered because it's being offered in other countries and being accepted in other countries. So therefore, let us see what is happening and explore it. But that's the problem. You're not getting proper communication. And if you don't have communication, you can't resolve it.
Based on what you're saying, Chairman, what I'm hearing here is it's not really availability, it's funding. So the drugs may be available, but funding is not available to acquire the drugs, which is a bigger challenge even. So I want to go to tobacco use because you spent a lot of time, explaining about the Tobacco Control Act and including vaping. And I want to ask you, your submission would have noted education plays a key role in creating the awareness of the harmful effects of smoking and vaping. From your end, what representation has the Cancer Society made to the Ministry of Health and other related state agencies, not just Ministry of Health, because I know you would have mentioned some of your conversations already. You have the Ministry of Education, because you're speaking young people and advertising. So other state agencies as well concerning the dangers posed by vaping.
So you want to know who else we've reached out to?
Of course.
Right. So we have, through Ministry of Health, we have gone into and education. We've gone into schools and we've done a campaign with Republic Bank and also with Scotiabank, with two major campaigns: Can't Fool Me and No Smoking, No Vaping. In terms of a continuous campaign, both ministries, we've not had support from them. So we do these initiatives on our own privately with those corporate sponsors. We do need that it is there consistently in the face of the young people. And it's not only high school level, but it's also primary school level, because we can't take it for granted. You know, people say, oh, they're young, or no, children are walking out to the youth rest with an iPad in their hand. So we need to understand the level of their intelligence. Their brain is there, and they're going to fall for those manipulative effects from primary school level. So we are asked, we have reached out to ministries, but they don't respond. There's a lot of lack of response, and I don't know why. And it's always about low-hanging fruit, but we have to hit where it needs to be hit. We can't just look for low-hanging fruit. We have to do what is necessary to really put your money where your mouth is. Do what you have to do, because if not, we're going down a slippery slope. And it's not just cancer, it's everything. You're having 30-something-year-olds dying of heart attacks, because between the smoking, the vaping, the energy drinks, and everything else, there's no proper lifestyle. So we have to do something. We're losing the younger members of our population, not only the older sector. And this is the NCDs. And then with the pandemic, it was even worse. That was an added layer, because we have sequelae from the pandemic. So this is a big problem. And if we don't start to make changes, we're not going to do any better. We're not going to achieve any single sustainability goal, nothing. Everybody will go to meetings, CARICOM will go to meetings, approve everything, and nothing being done. Nothing being done. And it needs to be effective.
Thank you, Chairman.
Thank you, Member Mohit. Breathe, Dr. LeBlanc. You know, I want to ask a question before I go to Member Naked and then Member Monroe for the remainder of our questions related to the Cancer Society. And this may be considered by some a controversial question. I'm not alien to controversy for some reason. Have you anecdotally or empirically information that you have seen since, one, the decriminalization of marijuana for private use? Because my small knowledge of marijuana, I'm not a smoker, I can't stand smoke, indicates that people sometimes smoke cannabis with cigarettes and on its own. And two, the liquid THC that is sometimes incorporated into vaping sometimes develops an addiction and a preference for cannabis. And is that also empirically or anecdotally contributing to cancer in Trinidad and Tobago?
Yeah, definitely. So if anybody knows my background, I'm a herbalist, but by no means do I subscribe to continuous use of marijuana. I want that to be known. So the thing is that decriminalization of marijuana has allowed the public to obviously feel free to use it more. We all know that they used to use it, but now you use it more. Now, what we've tried to educate is the fact that you're smoking marijuana, the heat going down can also cause cancer. It's not only the marijuana, it's the heat. What we've also we need to remember is that when you use an electronic cigarette, because they say, okay, don't use the cigarette, use the electronic device because that's cleaner. But it also it gives much more heat through the generator that it has. But not only that, it has other chemicals in there that will then cause popcorn lung and also inadvertently cause cancer. So it's not like weed is going to help you, because you're not smoking the fresh weed, and smoking on its own, that heat going down that respiratory tract is going to change the epithelium, the lining of the respiratory tract. So if I don't know if any of y'all remember long ago, you used to play barefoot and eventually your foot get hard because your body has to protect itself. So it changes the type of cells to protect itself. And with that change, you can be at risk for a cancer to develop. So smoking marijuana in any form, because of the heat, it will inadvertently put you at risk for cancer and other NCDs.
Thank you. What we're going to do is just let Member Naked and Monroe complete two quick questions, and then we come into the Diabetes Association. We thank you for your patience, but we kind of go through a logical process here, right? So Member Naked and Monroe, your quick questions, and then we go to the Diabetes Association and then the Heart Foundation.
Ms. Loba, your organization, TTCS, was instrumental, as you stated, in creating the Anti-Tobacco Bill of 2009. But you said it can help in reducing tobacco usage throughout the country. Can you elaborate on that comment and what specific elements of this previous bill should be introduced?
Right. So what happened with the Tobacco Control Act is that we were very good at getting it passed, and we got that done. It was amazing under Dr. George Lackey, who is our chairman emeritus. What happened was the Tobacco Control Unit could not effect the act properly from the Ministry of Health perspective. So now, starting maybe 2 years ago, we had talks, because we have talks all the time with the Tobacco Control Unit, and they said they're going to try and effect it. So if you will remember, last year when all the supermarkets were up in arms because we went down to the one dispenser only in the supermarket. So that was the first step in the right direction. Not to mention the one with not smoking indoors and all of that, that was okay. But effecting that aspect of the one cigarette dispenser, that was amazing. But we have more to do. We need to clamp down on the suitcase trade. We need to clamp down on the importation. We need to up that tax more, because if we want to effect proper change in lifestyle, we have to do better. And that is what the act is about. And then include vaping. We have to adjust that act to make sure it's very specific in words, because it's a very gray area and it needs the exact words, because these lawyers can find that the word is not there. And when they find the word is not there, then they say, well, we could bring it in and we can start making vapes. Whitco announced, I'm going to go into vaping because you clamped me down with tobacco, so now I'm going to vape. We have to make a change.
Chairman, she answered subsequent questions. So
Thank you. Thank you. Member Monroe, go ahead, please. Thank you for waiting.
Thank you very much, Chairman. Thank you again. Mr. Black, I thank you very much for your fruitful responses thus far. I would like to know, based on multi-sectoral collaboration, it was mentioned that one of the main challenge was the lack of public and private sector in relations to the prevention of successful multi-sectoral action in control of NCDs. Could you just quickly elaborate to us these challenges and what you think would remedy them in the shortest possible time, please?
Sure. I have to come back to the word communication and adequate communication. And we need timely communication. So the point lead in the Ministry of Health has to communicate to us properly in a timely manner, include us in the conversation, so that the campaign is not an empty campaign. Let the campaign be worth something. Let us continue it. Let it be sustainable and effective. We need much better communication to have better, effective cooperation. The NGOs are here to help. Yes, we're NGOs and we will do our work, but you can hear us if you unify and unite with us. We are the grassroots. And therefore we can help you, but listen to us and communicate with us. We know what politics is about. We know the bureaucracy will exist, but at some point, we need to wake up. We need to wake up, because while we're letting things happen in policy wise, I'm very sorry to say this, but all the higher ups, all those who have money, they try to do better in their lifestyle. But what happens to the poor man? What happens to them? We have to make a change. We have to try and do better. We just can't. The tobacco industry, you're not making tobacco. Use the damn land and make agriculture and let us try to live off our land. Cut our importation bill. We talk a talk, we don't walk the walk. And my ancestry dictates that I continue to remind us as CARICOM that we can feed our population, but we have to commit to it. We have to commit to it. That's our only way. We need to communicate better. We need to really effect change and put your heart in it. Don't just talk a talk. Put your heart in it and get it done.
Oh, thank you very much for that response. Also, I would have saw here that mentioned before, consultation with stakeholder groups are needed against the fight of NCDs in Trinidad. Can you elaborate on the stakeholder groups that you are speaking of here and the type of consultation required to really better this present situation? Thanks.
Yeah, so the NCD Alliance, the Healthy Caribbean Coalition, the Cancer Society, so the individual NGOs, but that's why we formed the NCD Alliance, so that our voices could be heard unified as well. We have the Healthy Caribbean Coalition, but it's just not heard. You know what I mean? CARICOM hears one thing, CARICOM says one thing, but the member states don't listen. And you hear very, very, dare I say, floppy, wish-washy excuses for why we're not doing what CARICOM says we should do. You understand? So yes, you know, we have to really just talk. They need to talk. Our point lead in ministry needs to hit with the NCD Alliance, and this Cancer Society has a seat, yes. The diabetes has a seat, yes. Dr. Capildeo, who is an oncologist, a very great oncologist in our country, he said to me the other day, we need a cancer point lead in the ministry. And I don't want us to be singled out because we're all NCDs. But it's like we don't get the right attention. Each NCD can't get the attention because it's only low-hanging fruit and to make you look good. That's what they're doing. And it can't be that. We have to effect proper change. You have funding, use it not only for low-hanging fruits. Let us hit the hard hitters, the high hitters. We have to do it.
Thank you, Member Monroe, and thank you, Dr. LeBlanc. We're hoping you can stay around with us for possible questions later on. But thank you for your passion and your conviction. I can hear the passion for this in your voice. I know some people may take it as dramatic, but I take it as passion, honesty, and candor, and I appreciate that very much. We're going to go to the Diabetes Association. Thank you, Dr. Danu and Ms. Dukuran, for your patience. And we can start with Member Naked in the line of question. Member Naked, go ahead, please.
Thank you, Chair. Mr. Dr. Danu, and apologies to Dr. LeBlanc if she left already. I kept calling her Miss LeBlanc. I wasn't aware of. I'm very sorry. Dr. Danu, you stated that your membership is 30% men. What strategies are you implementing to get an increase in that men membership? You know, men don't like to admit to having any kind of sickness or disease, and it's I call it ego affliction. So what are the strategies you implemented from your association to get more men to become members of your association?
Thanks for that question, Member Naked. I don't think it's exclusive of our organization. If you go to any single health center in Trinidad and Tobago, you will see most of them are women. It doesn't mean that the NCDs affect women more. Again, you say because of the machismo, because of other factors, men don't tend to seek healthcare until it's too late, or until it's very late. And that's why, that's one of the reasons men don't live as long as women. In the organization, it's the same thing, and I'm sure for Asante's organization, I'm sure for the Heart Foundation as well, it's almost the same in that women tend to take more proactive measures. Now, we have been doing quite a lot with men, in that we're trying to encourage them through the things that they like to do, through sporting activities, through community groups that we have, which is we do have about 20 branches throughout the organization. Quite frankly, we have been struggling to get more men to participate. But what we found is that when we get the women to participate, even though the men may not show up, the women will go home and give the men the advice. The women will go home and make sure the men are in line. And that is what has been happening. But I think it's really a cultural thing. It's something that we can't really do much to shift that culture. But I think it's that cultural thing. We need to work on it as a society as a whole, as a whole of government, whole of society approach towards this. Because it's not just Diabetes Association having this problem.
Well then, if you're talking about it's a cultural approach, and our culture tends to be very much inclined towards party and events and one-off affairs, then have you targeted these kind of things? As Dr. LeBlanc was talking about, she looked at the cricket, I think she said sports and all that. Have you done that? Have you gone into these kind of events to see if you can increase membership that way?
Yeah, I don't think we can go into a party with the Diabetes Association, but
why not?
Well, first of all, we do have events that are targeted more to men. So, for example, when we do have our 5K, for example, more men would tend to participate than women. And we do have screening activities specifically geared towards men. So, at some times for the year, we would try to target men more for diabetic eye screening and foot screening and so on. But again, there's so much to be done. Working with men exclusively hasn't been at the top of our agenda right now.
Okay, then just one more question as a segue. The Ministry of Health, they're having these kind of one-off events. You see them from time to time, walk around and all that. Has the Diabetes Association attempted to partner with the government on that, or are you part of that?
We usually are. So whenever the Ministry of Health has an activity like this, usually under the TT Moves banner, we are either invited or invited to come and have a booth, or even part of the planning process. There have been a few TT Moves activities where RHs have done outreaches, RHs have done 5Ks, and we were there. We were part of the planning committee even at some points in time.
Well, have you seen any tangible results because of that?
Well, I mean, yes, we of course see participation on the day. We see people coming out, but it's very hard to measure tangible results or results like that if it is there isn't a monitoring and evaluation framework established within that event. So I would say yes, it does encourage awareness. Yes, it does encourage persons to get screened, because at those activities we have seen that persons who have never been screened for diabetes or high blood pressure or so on before have been engaged and have realized that they do have these conditions. Of course, we do these types of screening every single day. But beyond that, I don't think it's significant, or rather, I don't think it's an appropriate spend for what we want to get out of it. Meaning that we could do a lot more with that money. As in the Diabetes Association, you could do a lot more with that money that you put towards a health fair, or to put towards that type of event.
In other words, the health fair it's not really a policy that can encourage more participation and membership.
Yeah.
Correct?
Well, yeah. Not a significant effort. It's not significantly able to do that.
All right. Let's move on. Your submission identifies projects and initiatives that the association has held over the past 5 years, with reference to the activities outlined under the children and youth activities. State how often these activities are held, and what does the sixth form internship program entail?
Sure. So all of these activities we do annually. So we have a schedule of activities, and all of those listed we do every single year. Of course, for the last few years, we've started new projects. The sixth form internship project was actually started 3 years ago. So this is the third year that we are going to go into it. The reason for this is because many sixth formers have often reached out to us, and they've always wanted to volunteer, because many of them who want to get into medicine actually need volunteer hours to get into medicine. So we have decided to create a structured program for them, whereby we are teaching them everything they need to know about being in an NGO, being in a health NGO. They would have taught them about research, taught them about fundraising, marketing and development. We gave them, or we even partnered with the Ministry of Health. We partnered with other agencies. They went to hospitals. They met the minister. They went to Guardian Media. They did all sorts of things. They did research and so on. So we actually were able to have these sixth formers. The first year, when we put out the ad for it, we had about 150 sixth formers registered. We took 35 because that's how much we could hold. Last year, we had over 600 registered, and we were only able to take 35. So this year, I know it's going to be even bigger, because there's no other program like this in the Caribbean, I think, where it's a structured program for sixth formers for volunteerism. These sixth formers have now formed our youth arm. So now we have over 100 young people on our youth arm. And these are the people who are there all the time when we do any of the activities to volunteer. And they're doing research projects, they're doing community outreach, they're doing activities in their schools. And these are the young people who, most of them are actually getting into medicine. So for example, last year, 7 of our sixth formers got national scholarships. Out of the 100 scholarships, 7 of our sixth form interns got scholarships. So they're really the cream of the crop when it comes to, and we are teaching these persons about advocacy, about healthcare, about working with people living with diabetes. These are the people who I want to run the organization in 10 years' time. So we're really investing in the future like that.
And your accredited diabetes educator program, tell us a little bit about that.
Sure. So this is a program from the International Diabetes Federation, which is the world umbrella organization for all diabetes associations. This program is an online, it's twofold, it's online and also in person. So we would have paid for and trained 35 diabetes educators. Then from that, we developed diabetes education plans. So we would have developed these plans so that these educators could go into health centers. We made a request of the Ministry of Health, and the Chief Medical Officer granted us approval. So, yeah, the Chief Medical Officer granted us approval to go to give us blanket and approval to go to every single health center for these diabetes educators to deliver lectures and talk to people living with diabetes. So we've had that permission. We've trained the 35 persons. We're now implementing the rollout. So we're now implementing the rollout where these educators would go to the health centers, teach people about foot care, teach people about taking medication, taking their insulin, how to take insulin, how to test, when to test. These are types of pieces of information that they don't get from the doctor or the nurse. This is information that you need to kind of figure out for yourself. Or join the Diabetes Association and come to our meetings, and this is where we teach you. So we have trained these educators, and we're sending them out on the field, sending them out in the health centers to be able to assist and teach people about these things.
You know, your submission talked about competing with other organizations for a limited piece of the pie. Mm-hmm. The resources that are available. It's quite troubling to hear that. Mm-hmm. Those resources, are you telling me that there's a piece of pie there, and you and perhaps the Cancer Society have to fight for those resources? Is that what it is? Explain.
Well, Asante is saying yes. I don't think Asante and I have had a physical fight before. Maybe a little bit verbal sometimes, but we know it's love. But as Asante, well, there are limited resources. And I mean, Asante is right, there are limited resources, and we do have limited resources that we have access to, not just at the government level, but private sector. I mean, Asante gets support from Republic Bank and Scotia. We can't get from Scotia and Republic Bank, and they're given to cancer already, or because, you know, so it's like that. Of course, we do have our sponsors. So we do have Tattle and Tattle Life, we have Ministry of Health, we have Blue Waters, we have sponsors like that who work with us. But they will exclusively work with certain organizations because it aligns better to their mandate. But fighting for resources.
Stick up in, Doctor, because I know you're pressed for time. Just give me an idea of what your operating costs are yearly. Can you give me that?
So it's approximately 1.5 million. That's our operating cost. It fluctuates because, of course, most of the costs that we have is for events. So we have only one paid staff member. Now two paid staff members. We have other staff members from OJT office. So we have OJTs, and most of our members here are volunteers. I'm a volunteer as well. Shoba is a volunteer as well. So we have a huge expanse of volunteers, and that's why we're able to do so much with 1.5 million spend. Now we don't get that from the government, but we try to raise as much as we can to be able to get the work done.
What do you get from the government? Sorry, Chair, your last question. What do you get from the government? Yeah. What's your
So our subvention is 400,000 per year. However, we do also get funds from the TT Moves program, the Health Services Support Program, for activities like our camps for children with diabetes, camp for overweight children, National Diabetes School Quiz, and diabetes symposium. Last year, that sponsorship or that support would have been around the area of 500,000 or so, a little bit less than that for those.
In addition to the 400,000.
Yeah, for those activities. Yeah.
Thank you, Doctor.
Thank you, member. Can I direct this question to Ms. Dukaran, who is the first Vice President of the Association. Two-part question. One, despite the great work of the Diabetes Association and public awareness about diabetes and the Ministry of Health, why do you think there seems to be a lack of response by the public regarding, and this is men and women, because I've had female and male family members who, they know their family has a history of diabetes, but they don't seem to link diabetes in your family or particular lifestyle habits with the damage that diabetes does to your body silently before it turns critical. Recently, I had a friend who is in his early 50s who has a family history of diabetes. And it's only when he got a small cut on his foot playing football, and it didn't heal for like 3 weeks. He went to the doctor, and the doctor said, well, let me test you. And he tested positive for diabetes, and he was on the verge of having the foot amputated, that he changed his lifestyle habits. And it seems only when it gets to that drastic stage that the message about diabetes gets through to men and women in Trinidad today. I don't know if Ms. Dukran wants to handle that first, and then Dr. Danu.
Yes, hello. Question. So I would say is there's a fear for people to acknowledge that they do have problems, and some of the effects that they will have with diabetes, it's a stigma to tell people that they are diabetic. So for me, that's one of the problems, and that's the fear of people acknowledging that they are diabetic people. Well, they are diagnosed with diabetes.
Thank you. Dr. Danu?
Yeah, Chairman, there are so many reasons for that. So many reasons for the hesitance people have towards getting tested or taking action. Shoba did mention the fear that people have, the stigma that's associated, but also the treatment. So, for example, you mentioned about the foot, and people don't go to, the reason we have, and we do have quite a lot of amputations. We have amputations daily, and the Ministry of Health has actually said that most of our hospital beds in Trinidad and Tobago are actually taken up by somebody with some diabetic foot problem. So diabetic foot problem and foot diseases are a huge issue. Now, one of the reasons why we know people don't seek care quickly enough is because they are afraid. They are afraid because the adage is that if it is that you have a cut on your foot and you're diabetic, you will get your foot cut off. Now that actually becomes reality because people try all different types of things, herbal medications, and all of these bush people are calling themselves doctors, claiming that they could cure everything known to man. And they go into these people, and only when it's too late do they actually present in the hospital. And then it's too late, the gangrene has set in. Half the foot is rotten off and need to cut it off or save the person's life. So this is one of the reasons why we are having all of these late stage diabetic complications, because people aren't going to seek care early enough. If it is you have that cut, then you can go to the doctor early and you can get it treated. If it is that you're losing sensation on the bottom of the foot, and that's one of the programs we're going to be starting within next month, which is a diabetic foot screening program. If you're losing sensation on the bottom of the foot, then you need to know what to do, how to take care of it, how to screen it. So a lot of it is about education as well. So it's a multifaceted problem. We are trying to deal with some of those.
Well, I'm glad you mentioned, sorry to interrupt you, I'm glad you mentioned education / public awareness, because you have your public awareness program. The Ministry of Health has its public awareness program. The other agencies that have public awareness programs, but the message doesn't seem to be still resonating. So we have to ask ourselves, is it the message? Is it the messenger? Is it the format of the message? Because at some stage, you have to ascertain if the attempts at public awareness and education is resulting in lifestyle changes and changes in response to making decisions about early intervention or early diagnosis or early checking that can save your life. I mean, the statement you made there to me should be front and center, which I never heard before. That a lot of the bed space is taken up by persons who have either a cut that won't heal or is on the verge of being an amputee. I think there's nothing that could rally someone to change their life more than that in terms of public awareness. So what are these analyses taking place, and why have there been analyses of the effectiveness of these public awareness programs, as opposed to just keep spending money because you think your message is getting through and it's not resonating on it and it's not having the desired effect?
Yeah, and that's a good point, because I mean, we often put out messages and we track what we try to put out. We could only do so much because we do have the money and we do have the resources to do as much as the Ministry of Health. Now, those messages that are put out may not be targeting all of the right persons, and they may not be going out in the right way. Or messages are going on, but how much of an effect does a message have? If it is that you want to screen your foot, okay, you have a cut, where do you go? What do? You are still afraid that you're going to get your foot cut off. All of these things we need to really address. And then at the same time, right after we give those messages, you have people on television, on the newspaper saying that you can come to them and they'll cure your diabetes. We come to them and we cure your cancer. We take my pill and you can do this. And these things are being allowed. These things are, and people are spending millions of dollars on these things. Everywhere you're seeing these things popping up and people calling themselves doctor of this and that. And they're not. And we're not dealing with it. And so many people I have known have come to us because they've been going by these quacks for so long. They're not getting the relief because there's one thing that...
Put a pause there. I want to dedicate 15 minutes to this later on, because I want to bring Dr. LeBlanc in on it to deal with this issue, because I've raised it already in the Parliament on the floor about persons who are unqualified, unregistered, and purporting to offer cures that in many cases leads to death that is unaccounted for. Let me bring Member Mohit in. Member Mohit, go ahead, please. Thanks for waiting.
Thank you, Mr. Chairman. And let me also take this opportunity to commend both organizations on your ongoing works. It is recognized. In terms of the Diabetes Association, Dr. Danu, what is your organization's take on supporting more stringent government policy interventions? For example, restricting on the promotion or advertising on certain items which may be unhealthy for persons to consume, etc. What's your position on that?
Yeah. So there are a suite of interventions that can be done which have been proven to increase the health of a population. These include taxation, these include limiting marketing, these include front of package labeling. The two that I think that are going to work best in Trinidad to be is front of package labeling and marketing, limiting marketing. Now, every single newspaper you open, every time you turn on the TV, you see a fast food ad, no matter what you do. And if we try to out-advertise them, it's not possible. The amount of money that they spend on advertising. Now, if it is that we limit that, if we limit the ability for persons to advertise or companies to advertise unhealthy foods too, especially children, because you're marketing to children. Marketing to children, you're getting them to love your food. They're sponsoring cricket matches and football clubs. So you're lying to them, they're giving scholarships. So you know, for the rest of your life, you're indebted to them. And these things need to be stopped. I mean, this is severely hindering the progress that we're trying to make. So all of this has to happen. We're trying to advocate for this government policy to at least limit marketing in schools, in school cafeterias. You're still going, you see advertising, you see posters up, and you enter in the competition and you win the soft drink and you win. So these types of things need to be implemented. The other is front of package labeling. I know Asante is a supporter, and I know Amit and they are supporters of front of package labeling as well, because we want simple front of package labeling. A black octagon on the front of a package that says high in sugar, high in salt, high in fat, to give a person the ability to make an informed decision when they pick up a product. Because so many people aren't able to read the label. They may not have the time to read the label, may not understand the back of the label. So we want that black octagon in the front of all the packages saying this product may be high in sugar, salt, trans fat. It's up to you if you want to consume it. So we need that.
Sure. You mentioned a UTAM, I believe, if I'm correct. You just mentioned education. How has your collaboration been with the Ministry of Education, your UTAM, etc., with other agencies in ensuring that you move a step further based on your recommendations here? Even the Ministry of Health. What's happening with your collaboration with these agencies to ensure that you have some step forward in the right direction, or maybe any type of consultation?
Yeah. So definitely with the Ministry of Education, we've grown very close in terms of implementation of projects. So we've decided to try to get into as many age groups as possible. So we started with the sixth form program. We also have a national diabetes primary school quiz, which is standard 3s. Last year we started a debate for form 4s. We actually think we need to intervene much earlier. There's a project that one of our champions, Hima Ramkisoon, actually whispered in my ear about, which I really like, which is with toddlers. We need to intervene with toddlers. We need to, that's really when habits start. So we want to work with toddlers and their parents and teach them how to cook and the snacks that they should have. So those types of interventions we are planning.
But as it relates to policy, in terms of
policy, yeah, we haven't worked with the Ministry of Education on policy. In terms of policy for the Ministry of Health, we have, of course, advocated for front of package labeling. Both Asante and I are part of the NCD steering committee of the Ministry of Health, and at that level, we're able to champion and able to give our thoughts on it. But of course, it's really just that, our thoughts and our opinions. It's really up to them to determine what's next.
Member Moore, can you just put a pause? Our colleague, Member Beckles, has to leave us early for another commitment, but she wants to ask a question before we continue with it. Is that okay?
Sure.
Thank you, Member Beckles. Go ahead, please.
Okay, it's just something I wanted to ask specifically about. It was asked before, and it has to do with children and youth, and how much people understand, because I understand myself about hereditary diabetes. Okay, I mean, I'm really asking the question because it's kind of hitting home. And how is that information shared? I mean, how could we access, especially for seeing now that you have, 7-year-old with diabetes and having to actually take insulin? I just wanted to read that. That's my only little quick question I wanted to ask.
Thank you, Member Beckles.
Thanks, Member Beckles. I think a part of your question I didn't get, but I think you're asking about hereditary diabetes and probably leading to type 1 diabetes. So both type 1 and type 2 have...
And let me just I don't want to forget, I'm asking about specifically now about children, 6 years, 7 years, 8 years. We're seeing it a lot more frequent. And I just wondered, in the context of what Member Mohit asked a while ago about the Ministry of Education, because I know personally of children who simply can't go to school. I mean, because, you have, it's not easy to go to school, and whether it's a teacher or even the child themselves at age 7 to have to be able to take insulin. So I just wanted to get a little feel on that. Thank you.
Thanks for that question. And yes, so particularly with children living with diabetes, now we do have approximately 200 to 250 children living with type 1 diabetes in Trinidad and Tobago. And this is the type that it's an autoimmune disease, and it's a very sudden onset, and you have children from as young as a few months old being diagnosed with this type of diabetes. They have to take insulin for the rest of their lives, as you said. A few years ago, we would have re-engaged the Ministry of Health and the Ministry of Education on a policy for children living with diabetes. Now that policy, I don't know where it is, it hasn't been acted upon, but some of the things we wanted to implement is, for example, teachers don't know how to deal with children living with diabetes. They don't know about insulin. Children are still being bullied. They have to take insulin in school, and children don't know about, they say they're taking drugs. Or some teachers, we've had issues where teachers didn't want the children to test, or they didn't want the children to to have something sweet when their blood sugar goes low. And we have tried to educate these teachers individually through our branch of the association that deals with these children, the Diabetic Youth Support Branch. We had plans to call out all of these teachers, or at least one teacher from each school, to teach them about diabetes and teach them about the things that these teachers need to know, how to deal with a diabetic emergency, so on and so on. We now have been linking up with Tutor and the NPTA, and we're hoping that we could implement that program this year. We want to teach a teacher in every single school how to deal with a child with diabetes, because we've had instances where blood sugars have gone very, very low and they didn't know what to do. And for many, many of these parents living with diabetes, their lives totally changed. They don't have a job anymore because they have to go multiple times a day to test their child. They could never have a full night's sleep as well. So one of the things we've actually started last year, we launched our continuous glucose monitors, which is that patch you put on the arm and you get your blood sugars throughout the day, every 5 minutes. Now, parents who have had it, they no longer need to go to the school all the time. They could be at work and see what's going on with the child, and so on. And these are some of the things we're trying to implement. We need to educate teachers about it. We need to get those resources. CGMs are very, very expensive. I know that the Minister of Health is trying to acquire them for these children, and I commend him on that. We're just waiting for them, but we know that's going to help out quite a lot with these children.
But of course, we're going to thank Dr. Danu and Ms. Lukman and ask you to hang around as we welcome Mr. Amit Maharaj back to the conversation. He is from the Trinidad and Tobago Heart Foundation, and thank him for being so patient. Mr. Maharaj, you've heard a lot of the conversation this morning. From the perspective of the Heart Foundation of Trinidad and Tobago, how much of the conversation can you relate to in terms of your organization? One, in terms of funding, and two, in terms of collaboration with the Ministry of Health in terms of getting messages of healthy lifestyles across?
Hi, everyone. So there's been a lot of good information coming from both Dr. Asante and Anu. From the perspective of the Heart Foundation, from its inauguration in 1998, our main mandate was education and awareness, because by the time a person does exhibit signs of heart disease, which usually comes in the form of a heart attack or a stroke, it usually is too late, and the quality of life depreciates for that person and for their caregivers and everything like that. So our main mandate is preventative, mostly through education and awareness, through health fairs, through lectures, getting information out there. We are also members of the Inter-American Heart Foundation, the American Heart Association, and the World Heart Federation, through which we got a lot of resources of research and everything like that, and we try to disseminate nationwide to the public. Another branch of our initiatives involves testing through our Know Your Numbers campaign and getting persons to actively test their blood sugar, their blood pressure, their BMI and stats and everything like that. What we also do, because we're not medical per se, that aspect of heart disease is not directly integrated into our mandate, but we do try to assist persons in getting them the resources that they need to get testing and stuff done. So in that aspect, we also have been encountering a lot of persons not getting the testing that they require when they get diagnosed of heart disease. So stuff like the stress test, the echocardiograms, the ECG, the EKG, a lot of times when they get diagnosed with a heart-related condition through the hospitals, they now come to us and they're not sure what to do, because when they go to book their testing through the public health sector, their test date is like a year, 2 years, and their condition is now. And by the time they get assessed of what the condition is, by that time it either worsens or the person is severely ill. And it is a snowball effect from the time of diagnosis to the time of when
How prevalent is that? Because we have had interfaces with the public too before, and more than one person just, I think it's last week in Chaguanas, a gentleman told us that he had a heart-related condition. I think he had surgery, and post-operative, even before he had problems getting an appointment, and then post-operatively, he got an appointment for over a year for a checkup. So how prevalent is this in terms of reporting coming to you as the Heart Foundation in terms of, one, the ability to get an appointment, two, the screening and testing at public healthcare institutions, and three, follow-up treatment?
So I know that there is a lot of persons who have been registered into the clinics, which the clinics do. They take their persons and stuff like that, which is not a problem. The wait times to be seen is hours on end, really, because of the load of persons that need to be seen. So usually what happens is that they go in, they see the doctor, not to the doctor's fault or anything, but the time frame that they get to see the doctor is maybe 5 to 10 minutes, and it's not actually the cardiologist, it's their team and stuff like that who prescribe the medications as, per discharge, from when they were in hospital. And it's just a repeat of the drugs and stuff like that to keep them going, to keep their condition stable and stuff like that. In terms of testing, the test, I've never actually heard someone actually gotten through with a test in a timely manner. It's usually always a year minimum. That's like the best case scenario. So persons who do need immediate testing to assess their condition usually have to go private if they can, and some can afford it, but many cannot. So it is a very tricky condition of getting the test results back in a certain time frame that the doctors, the cardiologists themselves, when they go back to clinic, can assess them and say, okay, well, this is what's going on, and we need to either modify the medication to help you, or do extensive testing, or schedule surgeries for the persons.
One of the persons who came to share their experiences with us told us that they didn't see the cardiologist. I think some other medical healthcare professional gave them a cocktail of drugs, and there was no follow-up to find out how they were responding to the drugs moving forward. That's one. And what's your experience with that in terms of your feedback? And two, what is your organization's information on the prognosis of heart-related patients who are not receiving regular post checkups or long appointments in the future while their conditions may be deteriorating, unless they can go back in an emergency mode because they can't wait that long and they feel their health waning at some point between the time they last visited the hospital, the public health care institution, and when the appointment is down the road, in some cases over a year.
Right. So usually that scenario, the first scenario with the repeat of drugs and stuff like that, is relatively a norm. And it is just that unless when we go out to our fairs and stuff like that, we also engage with persons who are on medication for cardiovascular related illnesses and stuff like that. And we try to guide them and tell them, are you having side effects from your drugs? Is everything okay? We try to get that information to them, because there isn't really a discussion when they go to their clinic visits. It's relatively, okay, how you doing? Okay, these are your drugs. Do a repeat, any major symptoms. And unless the patients know better to, actively ask the relevant questions to the doctors, which usually aren't the case, they tend to just get a script and go back to get a medication, and it's for another 6 months. So there isn't really a checkup on their vitals and stuff like that, except for like maybe blood pressure and weight that I know of. And then they re-prescribe the medication unless they actively say, okay, well, this is not working with my system, I'm getting this and the side effects. So we have to basically coach persons who are on medication to say, you have to monitor yourself. You have to, if your body's telling you that this medication is not working for you, when is your next clinic appointment? You need to bring it up with the doctors, right? So we are that liaison between getting persons to be advocates for themselves, you know, in this system, because it is relatively overpopulated, and obviously the quality of time for each person depreciates with each person who, you know, enrolls in the clinic system and things like that. Could you just remind me the second question that you? Sorry, I'm not hearing properly.
Sorry, I didn't turn the mic. And what I'm going to do in the last 20 minutes is just open the floor to member Mohit, member Naked, member Beckles, member Monroe, to any of the stakeholders before us in terms of our last round of questioning. So we can, members, you can pose questions to Dr. LeBlanc, to Dr. Danu, or Mr. Maharaj, or Ms. Dukaran on any of the issues we've covered, or any new issues you'd like covered, or questions you'd like answered from any of the stakeholders. I'll start with member Mohit in this round.
Sure, Dr. Danu, in your submission, you spoke of access to medication, and it mentioned that newer drugs which are proven to have a better effect on patients and not on the CDAP formulary. Example, Lantus, etc. Are you aware of any reasons as to why these drugs are not available via CDAP?
Yeah, thanks for that question, Member Mohit. And it simply comes down to the cost. Obviously, if it is that we are providing medications to persons for free, it has to be as economical as possible. Now, Lantus was on this. Lantus is just for everyone. It's a long-acting insulin, and it allows to control your blood sugar much better because it's a once daily shot. Especially for children with diabetes, it's very, very useful. Lantus has been taken off and replaced to some extent with 70-30 or mixed insulin, but it isn't, of course, the same thing. Now, it's much more expensive, and that's the reason why it was taken off firstly. But we are trying to make the case that, especially for children with diabetes, we should get this back for them, because it's what we're seeing is these children have HbA1cs, which is the measure that we use, in excess of 10. Now, HbA1c under 6.5 is normal. In excess of 10 means their blood sugars on average are like 300 and plus throughout the day. And we have children with that who have diabetes and they're not well controlled. So we're trying to advocate for getting Lantus and some of the other analogs onto the formulary for children, just to start off, just about 100, 200 of them. So we're trying to get that.
Sure. In your submission as well, it spoke to newer versions of the 7-30 mixes insulins have been reported to not be as effective. Can you indicate to us whether these drugs are still available via CDAP or whether they should be removed? And, you know, in terms of the Diabetes Association, what would you have done in terms of your recommendations or any consultation as it relates to this particular drug? If you can share that with us.
Yeah. So of course, when you do have a drug on the formulary, it's various generic forms from different suppliers. The supplier, I believe, last year was changed, and there was a Chinese version of the mixed insulin that was being supplied. We've had many anecdotal reports, because we haven't done a survey or a study to support this, but that the dosages, that the number of units that they would normally take, people normally take, haven't been effective at controlling the blood sugar. So we've brought this to the attention of the Ministry of Health as well, and they're looking into it. But many persons have opted to not use that CDAP provided medication or insulin, and instead decided to purchase their own. So that.
Can I go to Member Monroe now? Thank you, Member Mohit. Any question, Member Monroe, to any of the stakeholders before us here? We're asking 2 questions from each of our panels, our members, please.
Sure, Chairman. Thank you. My questions will be directed to Diabetes Association. Chairman, based on to Diabetes Association, based on submissions before me from y'all, in dealing with NCDs in Trinidad and Tobago and unsubstantiated non-medical practices. I would like to know, in your experience, can you elaborate on the main unsubstantiated non-medical claims that have been circulating?
Yeah. So there are two levels of this. There's of course complementary and alternative medicines, which we are fine with. I mean, this is the bush medicine your grandmother teach you and you grow up with. And Asante, of course, shaking her head, but using cinnamon and those types of things, that's fine. What we have the issue with is these people who are popping up and they're on radio, they're on television, and they are saying they could cure your diabetes, they could cure your cancer, they could cure your heart disease. They use these tests, and there are these probes now that they touch your hand and they put on your ears, and they could tell you all diseases known to man. And these things, I don't know how we're still allowing this to happen. We're allowing this to be on television, allowing people to see that you could come and you could touch my probe for $300 and you could know how much, if you have cancer or diabetes, and at the same time I have a tablet to give you, a tonic to give you, and it's going to work. Now this is nonsense, and we are allowing it to happen. There needs to be legislation to deal with these people, because billions and billions of dollars are being spent.
I'm glad you said that, Dr. Danu. I'm very glad you said that, because I'm going to ask this question of all of you. You first, Mr. Maharaj second, and Dr. LeBlanc third. Do you think the state should be more forceful in dealing with this, either through legislation or some other means? I'll start with you, Dr. Danu, and then I'll go to Mr. Maharaj and then Dr. LeBlanc.
Yes, I think the state needs to be forceful about this. I think legislation needs to be enacted to bring these people who could make these medical claims to criminal prosecution, because it really amounts to persons being not treated. It means that these persons are thinking that they're getting better, and they're really doing more harm than good, and they only show up into the health system when they can't do anything about it. These persons are essentially killing these persons, and I mean, we need to have this intervention done.
Thank you, Mr. Maharaj, and I've heard it said of hypertension also in terms of heart disease. What are your thoughts on this?
I also agree with Dr. Danu in terms of the misinformation that goes out to the public, because money and resources are being diverted from where they should, be invested into, which is proper care for persons with these conditions. And anyone who touts these type of medical claims should have a medical background to, purport what they claim to be, and not just providing this hopeful remedy for persons to get better, when in fact they're just using the person's money, time, and precious resources, when they could be rerouted to a specific path to get better, which is through the Diabetes Association or the Cancer Society, or medical practices that support their health.
Dr. LeBlanc, there's a medical act in Trinidad and Tobago which prohibits people who have not received medical training through a recognized institution to call themselves a doctor or to claim to be able to cure diseases. What are your thoughts on this issue?
It's the medical board does not seem to be able to enforce this act. I don't know why. I myself am an integrative healthcare practitioner, so I'm a certified medical herbalist. That being said, I always maintain, and if you look at anything I write or speak on, it does not have to be alternative. It has to be complementary. Now, when we call it bush medicine, I agree, Andrew, yes, it did arrive from bush, but the reality is there's a standardized format to herbal treatments now. And we have to understand and differentiate also the difference between supplement medicine and herbal medicine. And that is the cloudy and gray area. So the charlatans that are selling snake oil and claiming that they can cure and cure and cure, they have to be stopped. We see it all the time. We also see supplements being put up for recognition and for approval by Ministry of Health for Food and Drug. And when you approve them as supplements, they then go on TV and say we can cure. And that's not right. And we have to have some sort of legislature and effecting of that legislation, not only have it, but effecting it so that we protect the society. because people are looking, aren't you looking to be healthy? Aren't you looking to live till 90 and 100 and be able to walk and do everything? So when they're seeing that angst and that interest in that, they're going to prey on that. So we have to affect it. People who say that they can cure something, again, they're not doctors, so they can't cure it. And if you say a herb could, and you know what I tell people? Because they come to me, they say, look, moringa could cure me of cancer. I said, no, let me explain something to you. I do traditional Chinese medicine. If the Chinese thought that they could cure cancer with a herb, why in God's name do we have Chinese oncologists? You understand? So you have to break it down to them and you have to meet the patient halfway. I agree that there's a space for complementary medicine, but we do have to have some control mechanism in terms of that.
Member Naki, your question for any of our stakeholders, please.
Thank you, Chair. Yes, I do. To Dr. Danu, this is a question coming from someone who's watching actually on YouTube. They are talking about Ozempic and why it's unavailable. I have to ask a question. Why is it unavailable on the local market as studies indicate it treats type 2 diabetes?
But Member Naki, can Member Danu actually answer that question?
He's a doctor, isn't he?
Isn't that the Ministry of Health? Isn't that a question for the Ministry of Health?
No, but I would imagine, Chair, that he could give us some, at least a view as to
he could give us his views on it. Okay, no problem. That's permissible.
So my views on it. So one, what I do know, because we have been looking at this drug for quite some time. What I do know is there's a global over demand for it, and I do know of some distribution agencies, medical distribution agencies in Trinidad and Tobago have been trying to source it, but the producer isn't taking on any new markets because they can't keep up with the demand. What I can say is there have been a lot of suitcase trading going on with Ozempic and other GLP-1 inhibitors, GLP-1 agonists, and so on. But the thing is about these drugs, and I just want to tell the public, it's off-label use for weight loss, may have a lot more side effects than you think it does. And if you're trying to use it for weight loss, to maintain that weight loss, you need to take it for the rest of your life. Once you stop taking it, all of the things that it does, the suppression of appetite and so on, comes back. So that's a piece of advice there. It has been used or are very successful at managing type 2 diabetes, and we are hoping to have it. Besides Ozempic, there are other manufacturers who are making similar types of drugs. So we're hoping to have those in Trinidad as well. But be careful of the suitcase traders that are here in Trinidad giving you and selling you these drugs.
Okay, I guess that was very edifying for whoever asked that question.
Yeah.
My last question to you is about your submission stated that inaccessibility, as not all screening tests are performed locally. It's a main challenge identified by your membership. Can you provide examples of the screening tests that are not performed locally and explain that to the viewing public when you talk about performed locally?
Yeah. I do think we meant perform locally as in Trinidad, but performed at the point of care. So what we're advocating for is point of care testing. Yeah. So point of care testing, specifically for HbA1c. So the problem we're having in Trinidad is that HbA1c test tells you your average blood sugar for the last 3 months. What we're having now in many of our health centers, you go to see the doctor, you get an appointment to go get your blood drawn probably a month later. Then you come back to the doctor in 3 months' time or 6 months' time, and then you get an HbA1c result. So that HbA1c now becomes invalid because it's 3 months previous to that you're getting the result. Doctor can't use that to make any changes in your medication. So what we're advocating for is point of care HbA1c testing. You go to the doctor one time, stick your finger and you get A1c one time. At that point in time, the doctor is able to adjust the medication and know what's going on with the patient. Now, we have advocated for it. The Minister of Health last year said that they were acquiring HbA1c machines, point of care for every health center. So we're waiting for that. We're hoping that materializes this year, but we haven't seen that as yet.
So, in lieu, one more question.
I'm sorry, we have to end at noon, and you did say one more question.
Okay, sorry. Thank you, Doctor.
So much. I'm going to ask each of our stakeholders to give us their closing comments. We'll start with Mr. Maharaj of the Heart Foundation of Trinidad and Tobago.
Hi. Hello? All right.
Yes, we hear you. Go ahead, please.
Okay, great. Yes. So this forum was very enlightening. A lot of information came out that the Heart Foundation, is in agreement with as well with the Cancer Society and the Diabetes Association. And what we are hoping for is, some more resources to be allocated to public access in terms of testing and getting those tests readily available for persons and having their, quality of care improved in a more individual level rather than a general onset population of persons at the health centers or the clinics and stuff like that, so that persons would have a better reception of, medical care, looking after them going forward, especially those who are unable to reverse their disease or their NCDs.
Thank you. Can we go to Dr. LeBlanc, please?
Yes, on behalf of the Trinidad and Tobago Cancer Society, I do thank the members and everybody on the committee for having this this session. I hope it's not the last, but I also hope that the takeaways are used efficiently and effectively, our message is heard, and that we can really make a change based on meetings such as this.
Thank you. And both Dr. Danu and his colleague.
Thanks. My colleague Shobha had to leave, but on behalf of her and of course my board, I want to really thank the members of this Joint Select Committee, the chairperson, and of course Cancer Society and Heart Foundation. I really do hope, I want to echo Asante's comment in that we really hope that this does bring about some meaningful change in the way that we operate, in the way that we're able to get resources and share resources at that. So I want to thank everyone for that support and looking forward to what's next from these meetings.
Thank you very much. We'd like to thank all of you on behalf of the members of the committee. Dr. LeBlanc, the chairwoman of the Trinidad and Tobago Cancer Society, Dr. Andrew Danu, president of the Diabetes Association, and Ms. Shobha Dukran, the first vice president, and also Mr. Amit Maharaj, the manager of the Trinidad and Tobago Heart Foundation. Thank you all for being with us and your honest and candid contributions here today. We'd like to advise members of the public that our fourth town hall meeting will be coming up on Thursday, the 25th of April at 5 p.m. at the Arima Community Center. We invite the entire Arima and environs to come out and give us your views on your interfaces with the public healthcare system. We've had 2 before, and they've been 3 before, and they've been very, very fruitful in terms of getting direct information from you, the members of the public, on what your experiences are with the public healthcare system with in specific relation to cardiological diseases, diabetes, and NCDs in general. And we really appreciate the comments we've received before and hoping to see you in that interface. And also I'd like to thank members of the committee for being here today, including the members who could not make it, for their support, and of course the Secretariat of the Parliament for their always very, very strong support to this committee. We appreciate you being with us, and those of you who sent questions online and comments online, thank you so much for being a part of our interface today. At this time, we would like to adjourn today's session and wish you a safe and wonderful rest of today. Thank you so much.
Thank you.
Thank you.